Good evening, everybody. I'm Jean Shaheen. I'm the director here at the Institute of Politics, and I want to welcome all of you to the John F. Kennedy Jr. Forum. We have a fascinating discussion this evening about health care. But before we begin, I want to take a minute just to introduce David Luberoff, who heads the Rappaport Institute for Boston, and also Rosemarie Day, who is the Chief of Staff to Dean David Ellwood, who can't be here this evening but is very interested in this topic. And Rosemarie also was the former COO of the Medicaid program in Massachusetts. So thank you both for your help tonight. Tonight's forum is Expanding Health Care Coverage. What can states do? This is a topic that should be of interest not just to all of us here, but to everyone in the Boston area, to everyone in the state of Massachusetts, and to the entire country. We are facing a health care crisis in America. We have 45 million people who are uninsured, and the number is growing. Too often employers are refraining from hiring workers because of the high costs of health care. We have entire American industries, like the automobile industry, that can't be competitive because of the costs of health care. President Bush's recently proposed budget would cut Medicare and Medicaid funding in a way that would force states to make very difficult choices. Here in Massachusetts, we've all been following the legislature and Governor Romney as they struggle to reconcile different plans aimed at reducing the number of citizens who are without health care. The issues are very complex. There's a lot at stake. What can we do to address our health care crisis? Helping us this evening grapple with these issues is an esteemed panel. First, our first panelist is the president and CEO of Harvard Pilgrim Healthcare. He served as Secretary of Administration and Finance and Secretary of Health and Human Services during the Weld and Cellucci administrations. He received a master's degree in management from Northwestern University's Kellogg School, and he is a graduate of Harvard. Welcome back to Harvard, Charlie Baker. Nice to have you here. Our next panelist is the Eckstein Professor of Applied Economics at Harvard University. He's the author of Your Money or Your Life, Strong Medicine for America's Healthcare System. That doesn't get us thinking, nothing will. He served on the Council of Economic Advisors and the National Economic Council and the President's Healthcare Task Force during the Clinton administration. He's worked with the National Institutes of Health, is a member of the Institute of Medicine, and is currently a research associate at the National Bureau of Economic Research. Please welcome Professor David Cutler. Thanks for having David. Our next panelist is the director of the Harvard Kennedy School Healthcare Delivery Policy Program. He's chairman emeritus of the New England Medical Center and an adjunct professor of medicine at Tufts University. He's currently a senior fellow at the Masavar Ramani Center for Business and Government here at the Kennedy School, and was the founding member of several healthcare companies, including Meditech and Tufts Associated Health Plan. Please welcome Jerry Grossman. Nice to have you here. Our final panelist is a professor of health policy and management at the Harvard School of Public Health. She's also the director of graduate studies for health policy. She's currently the principal investigator of a project funded by the Robert Wood Johnson Foundation to study regulations of the individual insurance markets. Since 1995, she's been editor of Inquiry, a journal focusing on healthcare organizations, provisions, and financing. Please welcome Kathy Schwartz. Now, what I'd like to do to start our discussion this evening is to direct a question about our current healthcare situation to each of you, ask you to answer that, and then throw open a number of questions for all of you to comment on. So, David, I'd like to begin with you. Can you frame the issue of health care coverage for us? what can we do, what can states do to cure an ailing system?
I'd be glad to give you a crack at that. I think there are actually two issues that are involved, and let me just speak very briefly about each one. The first is extending access to health insurance to everybody. Currently, the biggest problem is not the very poor who are on Medicaid or the higher income who have access to private insurance, but the group just above there. There are different strategies one can use to reach that group. It turns out actually it's actually not a technically hard problem to design a way to cover them. You could expand the Medicaid program. We see many of these solutions in Massachusetts. You can expand the Medicaid program or other programs. You can offer people subsidies for private insurance. You can make them pay as individuals. You can make employers pay as individuals. We'll talk about all of these, but there's none of those that are that difficult. It's actually that one turns out to be a harder political problem than it is a technical problem. The real hard technical problem is how do you get the money to pay for it? And the obvious source of money is savings from what we know is inefficiency in the medical system. Probably about 20 or 30% of everything we spend on health care doesn't need to be spent. And in the nation, that's a $2 trillion bill. In Massachusetts, it's probably a $40 billion bill. So 20% of that is quite a lot of money. That's an easy political problem. Nobody is in favor of waste, fraud, and abuse. We've eliminated it countless times.
The same waste, fraud, and abuse.
The same one. We keep cutting it every year. It's a very hard technical problem to figure out how to do. So we're matched up with, on the one hand, answers that we could deal with and we could go if we could come up with the money, and what we're waiting for is the way to do that.
So, Kathy, elaborate on that a little bit.
Okay, so I think I would differ slightly with David. I think that, on the one hand, if you look at the uninsured population today, roughly 70% have incomes that all of us would agree are below what we would define as a middle-class threshold. And the other 30% have incomes that are high enough that the surprise is, why aren't they covered by health insurance? And I totally agree with David that the people whose incomes are below this middle-class threshold, we know what to do with, and it really requires money. We have to expand Medicaid, or we have to expand programs like the state children's health insurance programs, maybe to cover the parents of those kids, because kids are more likely to get medical care if their parents also are covered by a program like that. But the people whose incomes put them above this middle-class threshold that I've talked about, which in today's dollars is about $44,000. So if your income is above $44,000, you're what I would call middle class. And for them, I think what we've seen over this particularly last decade, is a real shift in what's going on with employer-employee relationships. And employers want to be out of this business of sponsoring group health insurance. And for people who work for small employers, this is not an option. For people who've been forced to become contract employees or self-employed, they don't have an option of an access to a group policy. So here's where states come in, or really I'd rather see the federal government come in. But you could imagine programs, and I think David's right, we're going to get at this, but there are technical fixes to this that we could be doing something to help people gain access to private coverage without doing subsidies directly to them, who are what I call middle-class people. And one option for that is what I've been pushing, which is reinsurance. So we've got some options here to play with. Part of it is money, but part of it is also explaining more to the American public what I think a lot of the American public already knows, that there are a lot of middle-class people without health insurance.
Yeah. Dr. Grossman, you run a hospital. Are hospitals doing everything they can to reduce the costs of medical care? There was a recent story, editorial in the Globe, talking about the tremendous profits that some of the hospitals here in Massachusetts are making. They're not profits, I understand. They're surplus revenues. But
why don't I let that slip by and rather turn to the second part of what David said. I have spent almost 40 years since I graduated from MIT trying to bring the best of management and engineering science to healthcare delivery. That's different than the medical sciences that the genome and its translational work has done. And of course, I happen to have the first piece of work done by the NAE with the IOM that I chaired, and it really does talk about using engineering, systems engineering and systems approaches adapted from other industries to truly transform how our healthcare delivery is both organized, structured, and operates. What I wanted to just add was it's very hard. It took us 2 years of a joint committee of engineers and doctors to agree that we had joint work to do. And if we are to come together, it's going to be a very painful learning. I do think we can begin to make progress, but by no means do I think we're anywhere near achieving what I agree is 20 to 30% savings from the existing system, but I wouldn't want to say that we just have to tell them to do it. So we really must engage in education, training, and research on this aspect of the delivery system. And it's got to be done in our research universities.
Charlie, as somebody who's been both in the public sector and is now heading up a health insurance company, are health insurance companies doing everything they can to cut costs and to be efficient as you provide coverage for people?
I would say that one of the great mysteries in healthcare is most of the people who are in it think they spend a fair amount of time trying to figure out how to make the system more effective and more affordable. And one way or another, that doesn't always translate into something that gets seen in toto by the outside world. And I think that's for a lot of reasons, not the least of which is that healthcare is probably one of the least transparent industries left. I mean, in this day of the internet and everybody has sort of the ability to go almost anywhere they want to collect data on price and performance on pretty much anything, except in healthcare. And I think one of the most important components of the reform plan that's being kicked around in Massachusetts at this point is all three branches, Executive, Senate, and House, have all basically said that transparency has to be a major part of healthcare reform. We need to create kind of a Bureau of Health Statistics that will have be empowered to collect data from plans and from providers and others, and to take that information and aggregate it and organize it and disseminate it and make it available to people so that for the first time, whether you're a citizen or a practicing clinician or a hospital administrator or a trustee or a health plan or an employer, you can actually start to think about this in terms of quality and performance and price. Because one of the great sort of mysteries in healthcare is there is a distribution curve in healthcare, just like there is in everything else. There are terrific performers and not so terrific performers. But we've taken kind of a don't ask, don't tell approach to that question because we just want to assume that everybody's above average because they're taking care of me. But the truth is, this is like anything else. And until we put the bright light on it and force the discussion and create some kind of place for truth around how people are actually performing, it's going to be hard for anybody to answer the question you just asked. And the plans have been very supportive of transparency and of creating more publicly available information because, frankly, we think that would be a good thing for everybody.
Well, and transparency would certainly help. I think I see everybody nodding, so everybody would agree with that. But that's really not going to pay for the people who are uninsured, right?
That wasn't the question you asked me.
I know. I know. So how do we get to that?
Well,
how do we pay for those people who are uninsured?
I actually think the Massachusetts when I worked in state government in the 1990s, we passed a major healthcare reform plan, and we enrolled about 300,000 people in our Medicaid program through that plan, and we got our uninsured rate down to 6%, plus or minus. It was the lowest in the country by a mile. And at that point in time, the economy tanked, and a whole bunch of things happened, and healthcare costs relentlessly increased. And one of the things we should all remember is that if costs keep climbing, coverage tends to suffer as a result. But, you know, the proposals that are kicking around include things like an exchange that would make it possible for small businesses and individuals to purchase coverage on a pre-tax basis, which they currently can't do. That's a 40% savings for a lot of them who currently either don't play because it's too expensive or have a hard time affording coverage now. They do have reinsurance in a number of the proposals, especially for the very small groups, 1 to 5, 1 to 6, to help subsidize the cost of their care. There's a whole series of reforms around trying to make more products available in the small group market. There's Medicaid expansion, and every one of the proposals differs depending upon how they're structured. And they all have sort of a mechanism to get at the question of, well, what about the employer? The Senate proposal creates kind of a free rider notion, which is if your employees access care and they don't pay the bill, then you'll be assessed as their employer for the cost of that care. There are other proposals that pursue an employer mandate, sort of a pay-or-play type approach, which has been around Massachusetts for a long time. And several of the proposals also have an individual mandate, basically working on the theory that if you get offered coverage at your place of employment and you don't take it, and you then use the healthcare system, you need to help pay for that. So I actually think Massachusetts is on the verge of hopefully passing a reform plan. And there's, as I said, there's a lot of transparency in there too. So I think Massachusetts is actually in a position where if people could find the common ground, wherever that is, we could do something pretty significant here.
So does everybody agree? Is it that? I mean, you've given us a
Well,
lot of
the
options.
common ground is hard to find,
Is that
but-
easy?
No,
Why
it's
haven't
not.
we done something if there are that many options and it's that easy?
I'd just like to come back to both
I didn't
what
say it was easy.
Charlie and David said. If we could solve the problem for next year, but if the rate of increase in costs continue at the rates it has, we will begin to dissemble in very few years. So there needs to be a two-sided approach, and that does mean spending, including in what Charlie said. I think for the 70% of people who use less than $1,000 worth a year, their payment of that part makes a good deal of sense. But for the 1% who use 30% or the 30% who use 70%, then it's time to turn to the provider community and ask them to be responsible for being paid on the basis of their performance, both in quality, outcomes, and the efficiency with which they do it, which is another outcome of transparency. But they need to be linked.
It's not going to be easy to get the provider community to go along with that, is it?
Certainly isn't.
David?
One question on, one answer to why does it seem so easy. Massachusetts has been down this road before. It passed, it had for many years on the books a health insurance mandate that was always coming up and always kept getting delayed. And then it would never happen. Ultimately, it was repealed. It's interesting and unfortunate what happens. So you say you need money from somewhere. Sometimes there's money from the state government. So, for example, the administration now says we have an extra pot of money that we'll devote to this. The extra pots of money tend to disappear, and so you have the issue of the longer-term financing. There's then an issue of, okay, if you're not going to do it that way, where does it come from? One place it comes from is some version of an employer payment. Okay. Now, what the economics of that is almost entirely that what that really means is wages for workers increase less rapidly. That happens at virtually all employers. It happens here at Harvard, for example. When our health insurance costs go up, the increase that we can give our workers in the wages is reduced, and that happens explicitly in union contracts and informally otherwise. But it's rarely perceived that way, so the biggest impediments are the employer groups, and in fact that's what happened in Massachusetts. The employer groups were very much opposed. They say all the businesses will move to god-awful New Hampshire, and we couldn't possibly allow that to happen. And so those tend to be difficult. And what you're left with, if you want it sort of in the political way, is the way that probably makes the most sense economically, is to say we're going to require families to have it, and then we're going to provide subsidies to those that are poor enough, sliding scale of subsidies so that people can afford it. I think it's the way that makes economically the most sense, because you don't have to deal with what about two-parent families and how much does this employer play, and if it's a temporary worker or a contingent worker. All the issues that Kathy said are rearing their head even more now than elsewhere. And it's interesting that one of the proposals has been to do that, although you very rarely find people willing to go there, because it looks like you're taking the load off of businesses and putting it onto individuals, even though in practice that's where it is always. So it may be that we'll sort of get over the hump and decide that we can do one or the other of those. Or it may be that we'll get stuck saying, look, we need this magic pot of money, we're not willing to do it. Or the third thing, which is what the other discussion was, which is say, you know what, we're going to commit ourselves to really doing a reform of this industry that will save the money, and then we're going to agree to devote that money to covering more people. And that's, I think, one of the things that's different this time is a sense that maybe we really truly can, through issues like this and like what Charlie was saying and what I spoke about earlier, maybe we really truly can get at it that way.
Do you agree with that, Kathy?
Well, yes and no. I mean, I think that one thing that we should be doing and talking about much more is the fact that we're already paying for health insurance or health care for people who don't have health insurance in a variety of ways. And essentially think of it as a ledger or an Excel spreadsheet where right now we say we're paying these types of extra payments either through our premiums or taxes that go for this or that, and point out that if we were to rearrange these dollars in a slightly different version on the different Excel spreadsheet, we'd come up with the same amount of money. It's just that the distribution of who would be paying would be slightly different. I suspect that a lot of higher income families would still be paying quite a bit, and they are already paying quite a bit generally because we are paying larger amounts in our premiums, as well as in our property taxes and income taxes. But that point, I think it's a relatively simple and obvious point to everybody in this room, but it isn't spoken about very often. And I think that's one thing that ought to be said much more clearly, and I think that David and Charlie are exactly right, that that's one thing that Massachusetts, at least having been down this road before, is somewhat cozying up to this idea. I'm not as convinced that you can get a lot of savings out of this by simply saying we're going to go after the providers. I think that a lot of the expenses of the people who are in the top 1%, where they do account for almost 30% of all healthcare expenditures for any group, one of the problems for these people is that rarely do you see somebody really managing their care. So oftentimes they have repeat scans or repeat diagnostic tests, lots of things that are done over and over again, sometimes for good reasons, but many times for not so good reasons. And to the extent that you might have, say, a reinsurance program, which Massachusetts has been experimenting with, at least talking about, there are a number of other states that are also talking about it in their proposals, less well developed, would be that it has incentives then for an insurance plan to really start managing the care of these very high-cost people. There would be tripwires, essentially, saying, this person looks like they're really going to be expensive. Let's think about managing it. That's where you might find money.
Right.
Yes, Jerry.
And almost all of the programs, disease management, other things, all come from outside the delivery system. I think we have to stand up. You said we have to talk about this. I think we have to talk both about the consumers and their use at the low end, and I do think we have to talk about what I call the agency status. We need a provider, whether it's a tightly managed HMO, a group practice, or an individual who will take management responsibility to be the agent who delivers complex care in an efficient way with good outcomes. Unless we can change people's structure and behavior, we're always going to be looking for another way to let them continue to behave the way they do.
So I guess I'm not quite following this. I certainly would not advocate then having a high deductible plan with a health savings account, which in your agency situation means that the person can go do what they want.
No, I was very careful. I said for low-use consumers, that might be reasonable. For high use, you got to turn to the agent who is a provider, not an insurer. See, I think for have the insurer be a case manager is not as good as you're letting the provider off the hook.
I don't think so.
Okay.
I think this, by the way, is one of the reasons why I think the transparency piece is so important. In the absence of sort of an agreed-upon set of facts about who's performing and who's not, we end up in sort of an anecdotal debate about what's going on out there. And I think the anecdotal debate in healthcare is sort of the nature of the debate. And that's because it's not a place where the information is easy to find and easy to come by the way it is in other sectors. And I don't think there's ever been the kind of pressure that can be brought to bear by a real free-flowing information set that you find in other parts of society and healthcare. And I will say, Jerry, that we have about 50 or 60 nurse case managers who do almost nothing but work with very complex, high-cost cases, and I get rock star fan mail from members of ours about the work that these people do, helping them navigate and manage their conditions through the healthcare system. And whether or not that's an appropriate role for the plan as opposed to the provider, I think we can debate. But I will say this, there's no question this is voluntary, nobody has to do it, but people really appreciate the fact that somebody who knows what they're talking about and speaks English or French or German or whatever their language is in layman's terms can help them figure out how to work through a very complex and often terribly fragmented healthcare delivery system. Because the system's built like this, but somebody with, by condition almost, but somebody with 5 conditions is trying to manage their way through it this way. And it's very hard to do.
I have no question. You said your members tell your case managers who are nurses that they are rock stars because they manage to coordinate the care and explain it. I expect that we need to get, that doesn't say that in the end we don't do still too many things, that things fall through the crack.
Yeah.
So I'm going to, keep saying we may not be there now and we need to do what you're doing, but I think we need to keep the pressure and the focus, and when we get this data, on getting the care delivery system to perform better.
Can states really solve this problem, though? I mean, what we're hearing coming out of the federal government right now are proposed cuts in Medicare and Medicaid in a way that would really make it much more difficult for states to solve this problem, to expand coverage, to do the kinds of things that you're talking about.
I mean, I think Kathy mentioned the premium that people who have coverage pay for care that's provided to people who don't, this cost shifted onto them. That's actually peanuts compared to the cost shift that lands on the private sector from Medicare and Medicaid cuts in payments to providers. I mean, the uninsured probably makes up plus or minus 2 or 3, maybe 4% of most hospitals' encounter activity, but Medicare and Medicaid make up about 50%. The other 50% is private payers like us, and every year for the last 4 or 5 years, most of my conversations with my colleagues in the provider community start with, okay, this is what I need to pay for your members who are part of the 50% of my delivery system that I incur costs for, and then this is what I need for you to add onto that to fund the shortfall that's being created by continuing cuts in Medicare and Medicaid. And and what's happened to some extent is state and federal officials, and I used to be one, so I'm allowed to say this, have figured out that they can shift a significant amount of care delivery burden from the public sector to the private sector without having to use the T word, simply by reducing their rates of payment on Medicare and Medicaid. And that's a big nut, and it's getting bigger every year because that represents such a big piece of the provider community's revenue base.
But that's a nut that's really being driven. I mean, as governor, the fastest growing line item in our budget was the cost of Medicaid. And the cost shifts were happening because we were not getting the money that was promised by the federal government to pay those costs. And so we were looking for ways to figure out how to continue to cover people with a shrinking pie. And that's what's going on across the country. So, we've all talked theoretically.
I wasn't defending it. I was just explaining it. Yeah.
I know. But we've talked theoretically about all these great things that would help address the problem, expand coverage, reduce costs. But until somebody takes a macro approach to doing this, how are we going to do it? David?
Just two comments. One to go back to your statement and to reconcile your statement with Charlie's statement. How is it possible that your costs are going up so much and Charlie says you're underpaying him? Or can you both be right? And the answer is yes, you can both be right.
Good.
And so I won't force arm wrestling here. But here's the reason why. It's because what's happening in Medicare and Medicaid and throughout the private sector is people are getting more services. So let's take a patient with relatively severe mental illness who would be on Medicaid. The availability of different types of drugs for that patient would be expanding. The number of physicians who would be involved in the care would be expanding. And so there would be more bills, more things done for the patient. And then you as the governor would sit there and say, oh, the costs are going up. What should we do? Let's reduce how much we pay for each bill. So for the same service, you reduce the payment for it. And then Charlie says, but now these doctors are coming to me and saying, look, on each service we get, we're getting less money, so they're causing me to make it up. And so we're in this sort of dysfunctional relationship where, pretty soon we'll be demanding that hospitals pay the government for the privilege of seeing patients if we keep cutting prices enough. So that dynamic clearly has to end. If you say, is that really going to? And there are two parts of it. There's the sort of money for the government to, let's say, expand coverage, and it's very hard to raise that money locally because of the issue of the border mobility and so on. So if everyone had their druthers, they would raise the money more centrally. Federal is better than state. State is better than local. If you imagine Boston imposing a tax on residents of Boston to pay for health care in Boston, house prices in the suburbs would boom as people moved out of the city of Boston. So that's clearly not going to work. What is particularly local are these things about making the health system work better for people. If you're going to have an insurance exchange, the way that Charlie was talking about, and give people the pre-tax status, that's a local function. If you're going to talk about integrating the provider systems and so on, that's a local function. If you're going to talk about what Kathy spoke about and finding the people who need to be there and dealing with the middle class folks and what you're going to do with those who have the ability to pay, that can very well be a local function. So the actual operation, I think, almost has to be a local function. I think it's been a mistake to try and do everything at the federal level because it really looks like what it is, which is not dealing with the problem in any particular area. What you want is to raise the money there, but have the action be down local. So this emphasis on the local level is I think, quite warranted.
Let me just add that, when you talk about this Medicaid and the cost shifting, remember about 2/3, somewhere between 60% and 67% of all Medicaid expenditures really are due to elderly and disabled people for whom the state has responsible for long-term care costs. And they're not at all the uninsured people. So the populace thinks we've expanded Medicaid and these costs have gone up, or at least the expenses for Medicaid have gone up, and they put A connected to B when in fact there's C that's really going on here. And that's something that David is exactly right. This is a problem nationally, and we have elderly people certainly moving around at different stages of retirement, and we ought to face up to that and talk about that more. And that becomes a political issue.
Well, and I'm sure all of you remember when the state of Oregon, probably about 10 or 15 years ago, looked at who they were covering under Medicaid and ranked in priority order the kinds of procedures that they were going to cover. And there was quite an outcry from the public about that. But should we be thinking about a system like that?
But I think that part of this, whether states are willing to agree that they're going to send more money to Washington and it will be dispersed to other states, you just read the headlines from the last 2 days of what the Medicare part of the president's budget is going to cost Massachusetts or New York, and that's been the headlines, as opposed to thinking about this of, well, wait a minute, these cutbacks in the Medicare payments to the providers is what I'm talking about.
Those are big numbers, and they splash really hard. I mean, when the
right, but we
Balanced
should be talking
Budget
about
Act
this
was
as paying taxes.
Well, now you're getting to the nub of the.
Yeah.
Someone finally said the tax word.
That's not true. I said the T word a minute ago.
Okay.
Texas?
Texas, right. and I think the drum is getting tighter and tighter and tighter. Because not only do we have more services to people that are better being given to each and every one, we do have a matching decline in the federal contribution to covering those patients here. And what we haven't talked about is the latest impact of your favorite thing, GASB. There's FASB and there's GASB. That's the Government Accounting Standards Board, which just joined FASB in asking every state and locality to put on their balance sheet the future costs of medical care. So what we haven't
For their employees and
retirees. What we haven't talked about is that not only is there Medicaid, there is a large number of state and local employees, all the teachers, firemen, and that they have private health benefits, which have to be paid for by the public. So I think that we need to begin to try to face up to what are going to be a very tough set of years. If we can't raise taxes and we can't control the rate of increase in costs, then we're going to be probably not able to really do as much about the uninsured as we'd like to. It's a zero-sum game to some extent.
On that pessimistic note, we're going to take some questions from the audience. We have 4 microphones, 2 on the floor and 2 up in the loges, and we just ask that you identify yourself and ask a question, trying to keep your questions brief and to the point. Yes, sir.
Hey, doctor, how are you?
You might try moving the mic down a little bit.
Hello.
Walter, you've got a booming voice. Just go for it.
I'm Walter Harrison from the Academy of Pediatrics. I've known Charlie for a long time. Sorry, I've seen you for years.
I'll just let that one go.
Good.
There are 3 areas that I'd like you all to comment on. One is you get what you pay for. Our expenses are huge and are increasing, and nobody seems to understand that. The population is aging, the technology is increasing, and therefore our costs are going to be increasing. And yet they say, well, cut your taxes. It doesn't work like that. There's not enough money in the system, number one. You can get savings, but it's a problem. The second area is the whole idea of preventative health care. As a pediatrician, that's where, as far as I'm concerned, that's where the money is. We've gotten the private health plans to actually pay for formal screening for developmental, mental health, substance abuse, and autism screening. The state still hasn't done it, which I hope they'll do it. But it's hard to get people to do this because they can't justify it fiscally this year, where the savings are cost avoidance down the road. And I don't remember what my third point was, but that's enough.
I would just start by saying that we all know we spend more on healthcare, and part of the reason we do is because the healthcare system can do more things for more people than it could last year, and somehow that never gets calculated anywhere on the accounting of society and life generally. And I know you've done some work on this, so I'd actually like you to talk about it for a second when I'm done. But I think I don't know what the right answer is in terms of the run rate on healthcare spending, but there's no question that a lot of people live far better lives and more productive lives than they would have as a result of some of these advances. And the healthcare system doesn't really get the credit for it, I think, because it's hard to calculate. And on the second one, Walter, I would just say that the most preventive things we can do when it comes to our own healthcare is eat right and exercise. And we've had a really hard time moving in a positive direction on those.
Let me just pick up the first question. We spoke about the waste in healthcare, and you say, well, is all of the increasing cost of medical care wasteful? That is, would we be better off just going back a decade or two? And so the answer to that, and it's really what Charlie said, is you have to think about, are the services worthwhile or not? The vast bulk of the services, while we know there's a lot that doesn't need to be done, the vast bulk of it is in fact services that are quite valuable. If you look at how long and in what quality of life people live today compared to 5 years ago, 10 years ago, 20 years ago, we're immensely healthier, and part of it is because on some dimensions of behavior we're better, so we smoke a lot less than we used to. And a large part of it is because we have much better therapies. Pharmaceutical therapies to prevent disease, better screening technologies, better therapies in very intensive settings. People really value their health a lot. That's what we learned when we stuck them all in managed care and they hated it, is that they don't want to save money if it means they give something up. And so if you look at what have we gotten for what we've spent over time, the answer is we've done amazingly well. We've carried along a bunch of waste, which we ought to get rid of, and we've spoken about. But as a whole, we've done very well. And I think, and so my thinking is exactly where you ended up on that point, which is what we ultimately need to think about is if as a society we want to spend more on medical care, great, let's do it, and then just get in place some rational way to finance it. Get rid of the waste that you can, but then say we're going to pay for it.
But that's small consolation to the people who are out there who don't have medical care and it's not being paid for.
And that, yes, and so a part of any of this has to be covering everybody. You can't have a system where you say we're going to have lots more good things, but only if you're rich enough to afford it. We're happy with that in other markets. We're not happy with that here. And so it's got to be part and parcel of that.
Yes.
Hi, my name is Alana Mendelson. I'm a freshman at the college, and I'm also working with several other students here to run a policy program on healthcare in America. And my question is about preventative care in America. There was an article in the New York Times, actually a series about type 2 diabetes, and I know some of you read that, and it was talking about how doctors are actually struggling to fight a system that rewards doctors for performing procedures that, for people who suffer extreme complications from type 2 diabetes, but doesn't actually fund the doctors to create programs to prevent these complications in the first place. And I know we're struggling right now enough just to create a healthcare system that provides care for people who do get sick. But as we look to the future, how can we incorporate preventative care so that fewer people actually do get sick and create a system that is more effective and actually does a better job to promote health in America?
I think, just to give you sort of one example along the diabetes line, this is where a number of people have been experimenting with bonus programming and pay for performance, which is code word for all kinds of things. But we've found that by creating financial benefits to the physicians we do business with, if they engage in sort of best practice behavior for our members who have diabetes, which means things like annual eye exams, regular screenings on their sugar levels, and aspirin daily if they need it, and a whole bunch of other things, which are all sort of very primary care focused and very preventive. you can act, and then you got to educate the member and make sure they follow up on that. And we spend a fair amount of time outreaching to the members on that stuff too. You can dramatically improve your performance in helping improve the health status of your members with diabetes and actually reward physicians financially for doing that. And I think you're likely to see over the course of the next few years a lot of focus on opportunities where better work on a more coordinated basis done with particular populations like folks with diabetes will translate into higher payment for physicians who do so. And that's certainly been our case.
Yeah, and I'd like to reaffirm what Charlie is saying, is that's aligning the incentives of both providers and consumers. You've talked about doing both of those things. And I think that's a critical part of our doing the better job we know how to do and being able to find some of the savings that we need. But that's a very important view, is to align the goals that we have for both our providers and our patients in the same direction.
David?
You asked earlier about national versus state and local activities. This is one example where a local activity may actually be preferred to a national one, because if you say, what is the biggest impediment towards getting even better care, would be that one insurance plan is paying this way, another insurance plan is paying this way, Medicaid is completely out to lunch, Medicare is wherever. And there's no reason why in a locality you couldn't decide, look, we're all going to say that these are our key priorities.
That's a really good point.
For our area, and that we're going to together come up with some system that addresses those patients so that we're transmitting a uniform set of incentives. First you measure
the bonus,
and then you say what's, and it's going to be much more effective when there aren't 7 different versions of it going out.
the bonus programs around diabetes and some of these other disease management programs in Massachusetts for Harvard, Tufts, Blue Cross, Fallon are all structured exactly the same way. So basically,
and so they can
it's
have a much
it's
bigger.
the same
Whereas
methodology.
if you go to
for
other
everybody.
areas, it's just
Not that way.
It's just complete bedlam.
Great. Next question.
Hi, my name's Andrew Miller. I'm a freshman at the college and also a co-leader of the new IOP healthcare policy group.
Note this commercial here for the IOP Healthcare Policy
I was
Group
wondering where I was going to send my check.
on healthcare. Yes.
I have a question about doctors' professional associations. When Governor Doyle of Wisconsin came to Bob Graham's seminar on kind of state governance, he expressed a lot of frustration at the state of relations between state governments attempting reform and doctors' professional associations like the AMA and others. Can you talk a little bit about where the greatest opportunity lies for cooperation with doctors as states try to move toward reform, and also what the greatest obstacles are? Thanks.
Great question. Who wants?
I spent 8 years working this one when I was in state government here, and I would say 3 things about it. The first is you will never be able to pursue a dramatic and radical and completely different kind of reform plan and expect the associations and the medical societies to say, hey, that's really terrific, sign me up, okay? It has to be. You basically have to engage them in a conversation that says, okay, we're here now, we'd like to get to here. And we're not talking about if, we're talking about when. And we're happy to help you figure out how to help us participate in getting from here to here. But what you need to understand is if you try to stop us, then we're going to pursue it anyway, and do it on top of you. But if you want to work with us, we're happy to do that. And I think, so number one is, you got to recognize that the societies and the associations have a constituency. They need to demonstrate value to that constituency, and one of the ways they demonstrate value is by proving that they're part of the process and part of the solution. And I think one of the things people in government tend to do sometimes is to think just because you think it's a good idea, they should too. They need to be able to process, engage, and participate, and basically create kind of a momentum on that they can take some credit for. The second thing is, and this is just a little cynical, okay? If you can come up with a proposal in which you're pretty sure 50% of them are going to like it and 50% of them are going to hate it, that proposal has a real opportunity for success, because you basically split the constituency, and that's when you can really get them into the conversation, okay, how do we do this over time? But if you want to do something that 85% of them are going to hate straight out of the gate and 15% of them are going to like, then you're almost destined to sort of line them up against you right out of the chute, and that will work against you. And the third thing is, generally speaking, there are key influencers within these groups who sometimes have official positions and sometimes don't. And you need to have spent enough time with them to know who it is that they really listen to and who it is that helps them make decisions about what direction to go in, especially if you want to do something that's a little different than the norm. And I think one of the things we tend not to appreciate sometimes when we're engaged in this is that this is human nature 101, just like everything else. And there are crusty old curmudgeons who are parts of these groups whose opinion really matter to their peers, and then there are the young, brash hotshots for whom this is the case. And if you can figure out who those people are and bring them into the conversation and basically say, I want you to help me move this thing in this direction, and sort of let them in on the ground floor to help you frame it, you're likely to be a lot more effective.
Yes, I'm going to actually take the next question so we can continue to get around to the questions. And
That's okay.
so we'll cut Charlie short on this next one. Yes.
And I used to do health policy work at Harvard, and I'm now on the board of the Cambridge Health Alliance. Speaking of preventive work, does great preventive work with diabetics and asthma patients, but they lose money because mostly their patients are on Medicaid, and Medicaid pays for hospital treatment, but not the outpatient care. And that's not our policy, it's the reimbursement. But my bigger point is none of you have mentioned the fact that in the U.S. we spend 30%, something like that, of our healthcare dollar on administration. And in Canada they spend 2, 3, I don't know, a fraction of that on administration. And it's because they have a single-payer system. We have multitudes of insurance companies, each with different rules. Medicare has rules, Medicaid has rules, hospitals, doctors have huge accounting departments figuring out how to get reimbursement. You do it this way if you're getting it from Charlie, and this way if you're getting it from
We
Medicaid.
get the point. Thank you. Does somebody want to respond to
Charlie,
that
do you
point?
want?
I'm happy to, but I'm told I'm not allowed to talk. So, David,
But I just wanted to answer the other question first before we get to Charlie. And that is, as a physician, you need to understand we are trained to be very careful about change, changing the way we take care of our patients, and to be very careful about the next drug or treatment. We've had some bad experiences. So there is a complicated cultural issue of changing and adding to our responsibilities to manage and coordinate care and to feel that we're being reimbursed for it. There's a real barrier from the old fee-for-service system. So I just would like to speak on behalf of my colleagues that there are people who are willing to change, but they need to be helped to see it will be a fair change when it comes. As to what you've said?
My real short... You should talk about this one, too. But
okay.
My real short answer on this would be, I think the real trick in Canada is they got everybody into the game, okay? And it's sort of a single payer. I mean, it's really managed at the province level. It's funded sort of jointly. I mean, it's kind of a crude version of the way Medicaid works, only it applies to everybody. I mean, Medicaid is a state, federally, jointly funded program. The Canadian model sort of works along the same lines. I think the administrative thing, if we could spend less on administration, I think that would be great. But what's driving medical expense trend at this point is not administration, it's healthcare. And administrative spending actually as a percent of total spending has been going down for the last few years. A lot of stuff that used to be done manually is now done electronically. I think that trend is likely to continue over the course of the next few years. And I also think when I was in state government, because of the way state government's organized, the GIC, which is the Group Insurance Commission, which oversaw state employees, spent 1.5% of its budget on administration. and everybody said that was great. But its pension benefit for its employees was funded somewhere else, okay? Its capital budget was funded somewhere else. Its IT budget was funded somewhere else. And, one of the things governments do is they compartmentalize spending. And what you typically end up with when people talk about those numbers is not the entire spend on something, it's the departmental spend on something, which is typically just HR. I mean, it's headcount. But that said, I think the United States could learn a lot from Canada, because they did create a shared economic model that basically says, there's going to be a federal structure around all this and federal support, but we're going to have it managed at the province level. And I think in many ways, that's a much smarter way to think about this. And we have the mechanism, we sort of have a federal-state mechanism in place, and we should be thinking about how to maximize that.
But is there anybody here who thinks a single-payer system would actually get through?
Well, we sort of have one. It's
country?
called Medicare. I mean, and everybody's screaming bloody murder over the way Medicare works and what it pays. And if it weren't for the shock absorbers like me, who fund the delta between what Medicare pays people and what Medicaid pays people, there'd be a lot more issues around health care generally than there are. And the other thing I have to say is it took Medicare, 40 years to figure out they needed an outpatient drug benefit? Health plans were doing that 25 or 30 years ago. Other people have talked about the fact that we pay for certain kinds of services that Medicare and Medicaid doesn't. Big federal bureaucracies are really slow to move, and we shouldn't underestimate that.
Well, on Medicare, I don't think it was the federal bureaucracy that was slow to move. I think it was Congress that was slow to move to get agreement that this was a program that they were willing to fund. But, Kathy?
I agree with that, and I'm just going blank on what I was going to say in response to the trial. Oh, I know what it was. I think that one of the key things about Canada, though, is that everybody is in this program. And we, at least in Massachusetts, have started putting on the table the fact that we would require people to participate in one way or another. And I think that that's another thing that we could take away from Canada that could serve us all well, because if we have younger people like you in the risk pool, it brings down the per-person costs. And we need you in the risk pool when you're young. So,
yes.
I want to play out a dynamic for you and tell you that we may wind up there. The number of uninsured has been rising for the past 15 or 20 years. It'll continue rising by a few million more every year. What happens every so often is the number of uninsured go up, and states decide they're going to cover more people through the Medicaid program or through other kinds of programs. So you get this sort of ratcheting up. If we do much more of that, we're going to be in a situation where probably the bottom half of the income distribution will be, if it wants to get insurance or able to get insurance, will do so through public insurance systems. So after probably one more big expansion of Medicaid and related programs, we'll be in a situation where the bottom half of the non-elderly population and the entire elderly population will be on public insurance. And from there, there's almost no going back. You could claim you're running a private insurance system for the top half of that part of the distribution. But if I was in favor of a single-payer system, I would just kind of let things go on for a while. And we'd kind of by default make our way there.
in fact, that's part of what I was also going to say, that somehow we have to be thinking about how do we go from here to there. And you can't just have a magic wand that says January 1, 2007, we are going to have Medicare for everybody or universal coverage. And so walking our way through this in a way that happens within a decade, I would say, because I agree with David. I think we are very close to a tipping point where we have more than half of the population without employer-sponsored health insurance. And we've been rapidly shifting that way over the last 10 years.
Yes, next question.
Let's let Charlie just answer for a second.
I think that's a reasonable scenario. I think that's likely to play out that way.
Yes.
My name is Michael Atik, and I'm a personal care attendant part-time here in Boston and studying, and also took free care applications through a temp job about a year ago. My question is dealing with what can maybe bring a start to getting a good system going. And I've thought for a long time about the Veterans Administration and whether we've advanced enough that it's not necessary anymore, that the specialized medicine that it started to, its roots were in, has dissipated. So I'm wondering if that can be privatized, and if ensuring the soldiers, which is obviously very important and might start the whole country in the right direction, if that can work, in your opinions.
I think the Veterans Administration is a really interesting sort of case study in healthcare reform, and I would say a couple things about it. The first is that it was way behind the times and not in terribly great shape 20, 25 years ago, and it was an embarrassment, and it became a public embarrassment and a national embarrassment for a lot of political leaders who basically said, you know, these are people who basically put their lives on the line, and we should be ashamed of ourselves. And they stepped up and made a significant series of investments in enhancing the VA delivery system. But the other thing that happened is the VA delivery system runs like a hierarchy. It runs like the military. So if they say, you know, we're going to install an electronic medical record, and this is the electronic medical record we're going to install, and guess what? Everybody's going to use it. Have a nice day. So, I mean, I have often thought that one of the great advantages that the VA has relative to the rest of the healthcare delivery system is its very command and control around administrative processes and electronic medical records, and its formulary, and who it's going to buy surgical supplies from, and medical devices, and it gives it just a tremendous edge in purchasing and providing care for people. And I actually sort of think that it has a purpose, it is serving its purpose, and it's doing a really good job. And I get really nervous about mixing up its mission. Because I've spent a lot of time inside VA facilities, and they are super. And I just get everybody's focused, everybody is swimming in the same direction, they are completely aligned about what they're trying to accomplish and who they're serving. And I would hate to mix up their mission and screw them up, to tell you the truth.
Next question.
Maggie Huff-Roussel. I'm with Social Sectors Development Strategies, and I work in health financing internationally, mostly in developing countries. And I'm Canadian, by the way. I was really struck until this lady down here asked the question about Canada, how you're all discussing tinkering with this system, which is really a mess, the whole national system. And it is, as you're saying, going to change. You can't say it's going to change on January 1st. But there's no vision of how to get to some other point. And it's not just a single payer. The single payer is very critical, but it's the enormous fragmentation, people shifting costs back and forth, a lack of acknowledgement that the healthcare sector is not like any other market. Behavior transparency is fine, but we as consumers are never going to be able to make decisions because so much of the demand is driven by providers. You know, there's so many exceptions in the healthcare sector to how the industry operates. And other countries, it's not just Canada, it's the UK, which is better, it's Germany, it's France. They are less expensive, they have better all of our health status statistics. It's so well proven, you know, half the per capita cost. You hear complaints about waiting lists and things like this, but there are very long waiting lists here. I come to this system, I go to Canada, I go to France. And the states are trying to change some things, including things like drug. I mean, the way pharmaceuticals are managed in this country, it's crazy. I mean, the demand for prescribed pharmaceuticals since open advertising was allowed has trebled. And, you know, it's because the providers control so much the demand in this particular sector, and a lot of other issues like that. So I'm surprised until these last couple of discussions that there was so little discussion of really fundamental changes in the way we provide health and finance it.
So your question is, are there thoughts about fundamental change?
Yeah, I mean, it was a lot of talk that seems to me like tinkering with things that we've been tinkering with for decades, and there are lessons to be learned, whether it's the VA or Medicare, Medicaid, which if it were spread to everybody, which is what did happen in other industrialized countries. They started with a lower coverage and spread it. and where you have some control over quality, even the research you can do. It's hard to get a complete database here. You get it for Red Cross, Blue Cross Blue Shield, or the veterans, or we're doing a lot of work with military databases, but... Sorry.
Would somebody like to respond to her comments?
I think that you're right in the sense that we really need to be talking about ways to control expenditures, for example, which we have touched upon here earlier. But I think one lesson that every one of us sitting up here, and probably everybody in this room, learned back in 1993-94 is that if we try to do this all as one big piece, even though it might seem like the most rational thing to do and efficient way to do it, we are asking for trouble. And I think that it's part of what Charlie was talking about, that I don't know whether it's cynical, I think it's realistic, that if you end up with a lot of people sitting there on the outside saying, well, what about me? And I get hurt by this, they're going to start lobbing all kinds of small grenades, arrows, etc. And so I think what we're all arguing for now is let's do this incrementally. And the issue, at least on the table tonight, is what do we do about people that don't have health insurance? And can we get them covered? And I think that we are much more likely to be able to do something about restraining the growth in medical care expenditures if everybody is in the tent. So let's get people in the tent. And then we can deal with slowing the height of the tent, or whatever you want to use as the other.
We've got 3 more people at the mics, so we'll do those 3 questions before we close. Yes.
I'm Robbie Griffin, freshman at the college, and I'm not affiliated with the AOP study group.
Well, you should join.
And she actually basically said everything I was thinking about, but I was just, to kind of expand on that, wondering, on those fundamental issues, ignoring the idea of doing incrementally, because that's probably the only realistic way to do it, what do you consider to be the ideal end goal? Would you want to go to a universal single-payer or multi-payer healthcare system? And also, why do we spend twice as much per capita on healthcare costs as the other industrialized countries, while we're ranked below 20 on life expectancy for men and women and infant mortality?
I think part of the answer to your question, the second half, is people overrate the role of healthcare and life expectancy. The second thing I would say is that if you live to the age of 65, your likelihood of living significantly beyond 65 if you live in the U.S. is much better than it is in other countries. We have a lot of people, we have a very violent society in which a lot of people go way before their time, and it dramatically bumps down our overall mortality statistics. The other thing I would say is, while other countries spend less than we do per capita, we have much higher incomes than they do per capita, and income per capita, generally speaking, reflects the level of healthcare spending per capita that people choose to spend. And if you look at our spending, not so much on a per capita basis, but on a GDP basis, the gap goes from twice as much to about 30 or 40% more. And then if you look at trend, everybody has the same trend the U.S. has. I mean, the notion that all these other countries that have single-payer systems have solved the trend problem is simply not true. All of the issues associated with increasing medical technology, an aging population, and the capacity of the system to do more things for more people is driving up people's interest in spending money on healthcare relative to other things across the globe. And I guess, maybe when I was 20, 15, 18, I used to think this stuff was easier. And maybe now that I'm almost 50, I think it's not. But I think the bigger issue that you raised is, what's the end game? And I would argue that there is no end game discussion in Washington at all. And that in some respects is a huge problem for states, because a lot of what doesn't get done in Washington, or what gets done that's negative, splashes back on them. But I would say in Massachusetts, the end game, Republicans and Democrats, for the past 10 or 15 years, has been to get more people into the tent and to do it incrementally. And we've done a better job of doing that than pretty much any other state in the country. And I think in some ways, that's the game that people continue to play here. And is it pretty? No. Is it sort of preferred and easy to describe? No. But it's been pretty effective. I mean, if you look at where we were 15 years ago and where we are now, 15 years ago, there were a lot of uninsured children in Massachusetts. I mean, at this point, if you're uninsured and you're a child, it's not because there isn't a program there for you, it's because you haven't found it. And I think in some ways, the good thing about incrementalism, if you stick with it, is you make progress.
Great. Next question.
Hi, I'm Mike Miller. I'm a physician and health policy consultant. Professor Schwartz mentioned the long-term care costs and how much percentage of Medicaid it consumes, and I think the Governor mentioned how much Medicaid means to state budgets. In the budget bill that was just signed, I believe there's a provision that goes after what I think is the second largest sacred cow for middle class. That's the ability to transfer assets to your children, to other family members to get on Medicaid for long-term care. Is that new provision either an opening wedge or going to make significant differences in the ability of states to free up funds in the future for expanding coverage?
It's a good question, but it's not going to make a big difference. Yeah. There have been a number of studies looking at different states, what's happened in the past. There are very few elderly who actually transfer their assets in advance. Those who do become the anecdotes, as Charlie said, that we talk about. But in fact, a lot of elderly are very nervous about transferring their assets to their children in advance. And you have to somewhat know or believe that you're really going to need nursing home or long-term care. And a lot of people either don't want to face up to that or it happens unexpectedly to them. So the answer is no, it's not going to bring us a lot of money.
It's not a huge middle class entitlement.
It's a great thing for getting publicity.
Final question.
Hi, I'm Leo Stolbach. I'm a medical oncologist and have been taking care of patients in Massachusetts since 1964, except for 3 years when I worked up in Canada and saw how well a single-payer system could work. And I have to say that one of the issues in terms of Canadian medicine now is the fact that they are underfunding it. As was pointed out, they're spending half of what we are on health care. My question is how the members of the panel feel about the fact that we all talk about universal health care and you espouse universal health care, but it ends up being universal health care for most of the people, not everyone. And whereas all of the other industrialized nations consider health care a right, not a privilege. And here in the United States, it's a privilege. And there is a constitutional amendment which is up to be hopefully voted on in 2006 that would make health care a right in Massachusetts. And I'd like to hear your thoughts on this as an approach. It doesn't say exactly how it's going to be done. That is left up to the legislature. But it's going to make it a basic right the same way that primary education is a basic right in Massachusetts.
David?
If you take any poll of Americans and you say, should everybody be covered? You'll find 98% of people saying yes. So at the broad level of what do we want from our health system, there is a universal agreement. Where there's disagreement is over how much we're willing to pay, how to do it, whether it should be done through the public sector, through the private sector. So I don't know that just expressing our view that we like it. I sort of think of healthcare sometimes as the equivalent of world peace. We're all in favor of it. The question is how to make it happen and how much would it cost to make it happen. And trying to find some strategy that says this will actually get us to world peace at a price we can live with. And what's actually interesting about the panel is probably had you had this a decade ago, shortly after the Clinton plan failed, you would have found incredible discouragement about, we'll never get there, it's going to be another 20 years before we think of it. And what you're actually seeing now is much more hope that major steps are within our reach, that we have ways we've thought of that can do it, and that with some good luck and sound thinking, we can actually accomplish quite a lot.
Thank you. On that positive note, we're going to close. Thank you all very much, and thank you to all our panelists.